Hi, this is Mike Poulden. In this presentation, I will be answering the question, should CADTH adopt a societal perspective? You may download this presentation by scanning the QR code. Before we begin, I'm going to cover some disclosures and conflicts of interest. My only employment is as a faculty member at the University of Alberta. I was a member of CADTH's Health Economics Advisory Council, HEAC, from its creation in April 2019 until its dissolution in June 2023. During this time, I prepared a white paper for CADTH on its perspective. This presentation draws from some ideas outlined in that white paper, and I would like to thank CADTH for supporting the production of that white paper. The views expressed in this presentation are my own and do not necessarily reflect those of the University of Alberta or CADTH. And finally, I have no financial or other interest in CADTH's methods for economic evaluation. Let's start with some background. Since 1994, the Canadian Agency for Drugs and Technologies in Health, or CADTH, and its precursor, the Canadian Coordinating Office for Health Technology Assessment, have published guidelines for the economic evaluation of health technologies in Canada. A particularly controversial topic in these guidelines concerned the primary perspective of the evaluation. The second edition of these guidelines, published in 1997, recommended that, quote, the primary analytic perspective or viewpoint for pharmacoeconomic studies should be the comprehensive societal perspective. That is, all costs and benefits should be identified regardless of who incurs the costs or who receives the benefits. However, this had changed by the third edition, published in 2006, which instead recommended that the primary analysis should be, quote, use the perspective of the publicly funded healthcare system. The publicly funded healthcare system perspective was retained as the reference case perspective in the most recent fourth edition of the guidelines, published in 2017, with some flexibility. To quote the guidelines, where other perspectives are of interest to the decision maker and could have a substantial impact on the results of the analysis, these should be included as additional non-reference case analyses. These are the guidelines published by CADTH. If you wish to download them from CADTH's website, they're freely available. And then in April of 2023, the National Advisory Committee on Immunisation, or NACI, published a competing set of guidelines intended for economic evaluations of vaccination programs. An important distinction between these and CADTH's guidelines is that NACI recommends that both a societal and a publicly funded healthcare system perspective should be reported by analysts. And here are the guidelines. If you wish to download them, you can do so from the NACI website. It's therefore an opportune time to consider whether CADTH should 1. Maintain its reference case perspective as the publicly funded health system perspective. 2. Change its reference case perspective back to a societal perspective. Or 3. Require that both perspectives be considered within the reference case, in common with NACI's recent recommendation. And it's worth bearing in mind that CADTH is not alone in facing this dilemma about what perspective to adopt. So in 2022, the National Institute for Health and Care Excellence, which is the UK's primary health technology assessment agency, considered 3 similar options. The first was to retain a health sector perspective, which is exactly the same thing as that publicly funded health payer perspective that CADTH talks about. It's a different terminology for exactly the same thing. Retain that health sector perspective, but with flexibility to adopt a partial societal perspective in particular circumstances. So that is what NICE currently recommended or did at the time in 2022. The second option was to retain a health sector perspective, but, quote, strengthen internal processes to ensure flexibilities are used consistently. So those existing flexibilities would be strengthened and processes put in place to make sure it's consistently used across different evaluations by NICE. The third option considered was to initiate further exploration of formally adopting a wider societal perspective. And if you're interested in NICE's considerations and deliberations around this, I would highly recommend reading this document that's available on the NICE website, Options Appraisal for Adopting a Wider Perspective in NICE Assessments, a 21-page document published in December of 2022. Highly recommend reading this if you're interested in this topic. So here's an overview of today's presentation. First of all, we're going to consider what is a publicly funded health system perspective. Secondly, we'll consider what's different about a societal perspective. We'll then consider the potential for a societal perspective to discriminate against certain patients, and we'll talk about how that can happen. Then we'll consider the appropriateness of CADTH's informal $50,000 per QALY cost-effectiveness threshold. And we'll consider the impact of adopting a societal perspective both with and without modifying this threshold. So what would happen if CADTH adopted a societal perspective while modifying this threshold, and what would happen if they did not modify this threshold? And finally, some recommendations. Let's start with section 1. What is a publicly funded health system perspective? Now let's imagine that you have a public healthcare system and it has a constrained budget. And a new health technology is provided, it's launched, and this health technology costs more than existing care for those patients who would receive this new health technology. But the reason that we're considering this new health technology is that it provides expected health improvements for the patients who receive this. So this is a technology that's in that top right quadrant of the cost effectiveness plane, for those who are familiar with this terminology. This is a technology that would impose additional costs on the budget, but it also provides additional benefits to patients. Now, because that budget is constrained, those additional dollars required for the new health technology have to come from somewhere. And as a result, there will be less funding for other healthcare. And there's a variety of different implications. There could be longer waiting lists. There could be delisting of other technologies. There could be other investment opportunities foregone. And we don't need to look far to find other things that we could spend our limited healthcare dollars on. This is an article in the National Post from December of 2023. Canadians dying while on medical wait lists reaches 5-year high, report finds. And they say government data shows that more than 17,000 deaths among patients waiting for life-saving or quality life procedures occurred within the past year, I believe that figure was for. So a lot of Canadians are dying while on waiting lists. So one potential use of those dollars would be to shorten waiting lists for other routine therapies. Here's another article from the Edmonton Journal. As bad as we've seen it in 25 years, AMA president, the Alberta Medical Association president, sounds alarm as Alberta hospital wait times rise. So yet another article about waiting lists. Here's one from Ontario from January of 2024. Ontario hospitals warn of patient surges and long wait times. So this is a crisis that is facing public health systems all across Canada. And every dollar that is spent on a new health technology is a dollar that could be spent shortening waiting lists. Okay, where there are limited resources, we face tough choices, and each dollar cannot be spent twice. Here's an article from the CMAJ from last year. A national survey highlights worsening primary care access. And the most striking part of this article for me was this statement. More than 1 in 5 Canadians, so more than 20%, an estimated 6.5 million people, do not have a family physician or nurse practitioner they see regularly, according to a national survey. That's a dramatic increase since 2019, when Statistics Canada estimated only 4.5 million people did not have a regular healthcare provider. So that's another potential use of limited healthcare dollars. We could invest them in expanding primary care, in recruiting more family doctors, making sure that some of those 6.5 million Canadians who do not have a family physician have better access to a family physician. There would be health benefits arising from us doing that. So that's a potential opportunity cost of spending money on a new health technology. And as a result of that opportunity cost, there are expected health losses. So we spend money on the new health technology and it provides improvements for the patients who get it, but we forego the opportunity to spend those dollars elsewhere, reducing waiting lists, recruiting more family doctors, you name it. There's many, many other examples. And so there are expected health losses as well. And under a publicly funded health system perspective, that perspective that CADTH currently adopts, the purpose of a health economic evaluation is to consider the expected impact on the overall health of the population. So taking into account those expected health improvements, but then subtracting those expected health losses. And it's important to be clear, the focus is population health. The focus is not dollars spent or any other economic considerations such as productivity. The sole focus is the health of the population. Would this new technology provide greater health benefits to those patients who receive the technology than are foregone by other patients whose healthcare receives less funding because we've paid for the new technology? So under this publicly funded health system perspective, a treatment is considered cost effective if funding it is expected to improve the overall health of the population, if those expected health improvements are greater than the expected health losses. And the flip side of this is that a treatment is considered not cost effective if funding it is expected to diminish the overall health of the population, if those expected health losses are greater than the expected health improvements. So what's different about a societal perspective? And a good place to start is CADTH's 4th edition of their guidelines. And in these guidelines, Table 1 provides examples of different costs and outcomes by perspective. Let's zoom in on that table. Here's the top half of that table. So you can see that under the reference case perspective, which is the public healthcare payer perspective, that includes only those costs that fall on the publicly funded healthcare payer. So things like drugs and medical devices, procedures, equipment, facilities, all of the costs that fall on the public healthcare payer. There are 3 other non-reference case perspectives that are listed in this table: the private payer perspective, the broader government payer perspective, but we're going to focus on the societal perspective today, and that includes all of these different categories of costs. So in addition to the costs considered under the publicly funded health payer perspective, there's also costs to the private insurer. There are costs to government payers beyond healthcare, so things like social services, affordable housing, education. Here's the bottom half of the table. It goes on. Costs to patients and informal caregivers, so things like out-of-pocket payments. Cost of travel, paying for caregivers, premiums paid to private insurers, travel time spent traveling, receiving treatment. Productivity costs, and this is a very significant one. So lost productivity due to reduced working capacity or short-term, long-term absence from work. You could also have unpaid work, so housework, by the patient or family caring for the patients, and cost to employers for hiring and training replacement workers. So all of these different costs that are considered under a societal perspective, but not the reference case public health payer perspective. Then we move on to outcomes. And you can see that the reference case perspective that NICE currently adopts considers only health effects relevant for patients and informal caregivers. So health-related quality of life, life years gained, clinical morbidity. Under a societal perspective, we would add on the non-health effects. So things like information available to patients that doesn't directly improve their health, reduction in criminal behavior, better educational achievements, and so on and so forth. Another place that we can look for what sort of additional costs and outcomes would be added to the societal perspective is the NACI guidelines. And within these guidelines, the authors say, quote, "The societal perspective captures all health outcomes and health system costs from the health system perspective. In addition, it captures impacts that fall outside of the publicly funded health system, including healthcare costs not publicly funded by the health system, direct out-of-pocket costs, losses in productivity, consumption, education, social services and community services, and environment. Longer-term impacts such as the effect of childhood illness on an individual's neurodevelopmental impairment, educational achievement, and subsequent long-term productivity and consumption should be considered where relevant and feasible." And there are a number of excellent studies that have attempted to estimate some of these additional costs. So family spillover effects, that's one example of these additional costs and effects that could be incorporated within a societal perspective that are not included within CADTH's current reference case. So this paper was published last year. Another article that was published at the end of last year, very recent article, recommendations for emerging good practice and future research in relation to family and caregiver health spillovers in health economic evaluations, a report of the SHEAR task force. So this is well worth reading. So a lot of excellent work has been done and is continuing to be done on exploring what those additional costs and outcomes would be under a societal perspective. If we just return back to the NACI guidelines for a moment, the task force continued to say, The task group has given serious consideration to the adoption of two perspectives, with the acknowledgement that our arguments against the use of the societal perspective as a reference case. For example, the lack of an empirically estimated societal cost effectiveness threshold, and we are going to return to that later in the presentation, and also the lack of established methods to quantify select broader impacts into monetary terms. So although I mentioned a few moments ago that there is some excellent research going on right now, there are still many things that we know an insufficient amount about that are very challenging to model within a societal perspective. It goes on, the task group recognises that many arguments for or against this reference case involve normative judgment and social preferences. Hence, there is no correct choice. And I'm going to go out on a limb here and make a recommendation here because I think there is something that we can say. What I would recommend is the following. Where the purpose of an economic evaluation is purely descriptive, a societal perspective should be adopted to provide a comprehensive account of a health technology's economic impact on society. However, where the purpose is to inform a decision regarding whether to reimburse a health technology or at what price, the perspective must align with the values and principles of the decision maker. So in the first paragraph there, what do I mean by descriptive? I'm saying imagine you're looking at this from 30,000 feet and your economic evaluation is just trying to estimate all of the possible implications that this technology has. The cost implications, the implications for health outcomes, for education outcomes, you name it. You're trying to capture everything. And you're doing this from 30,000 feet. This is an accounting exercise, an auditing exercise. It is not actually going to impact upon the decision about whether or not to pay for this technology. Well, in that case, then, of course, you should adopt a societal perspective. You should put everything in that economic evaluation that you reasonably can. But the second part is where you're actually informing a decision, well, there may be some considerations that you do not want to go into that decision. And we're going to talk more about that in a few moments. And where that's the case, you don't want those factors to be included within your economic evaluation. So you need to be very careful. It might be problematic to consider a societal perspective to inform a decision if there are certain principles that this would contravene. So let's talk about this potential for discrimination. And as defined by NACI, a societal perspective includes consideration of losses in productivity, consumption, education, social services, and community service, among other things. It also includes consideration of educational achievement and subsequent long-term productivity and consumption. So let's begin by considering productivity. There are two common approaches for measuring productivity. The first is something called the human capital approach, which uses an individual's wage or salary as a proxy for the value of any lost productivity due to illness. So those individuals who have a higher wage or a higher salary, those individuals are considered more economically productive than other individuals with a lower wage or salary. The second approach is the friction cost approach, which considers an individual's lost productivity due to illness in terms of the cost to their employer to train another worker to do the same job. So where you have a pool of unemployed labour, if one worker is sick, the productivity loss is not necessarily what we were paying that sick worker. The productivity loss is how much would it cost to train another worker who's currently unemployed to do the same job. Okay, so usually those estimates are lower than the estimates you'd get under a human capital approach. But we can see a problem here, right? The human capital approach assigns greater value to restoring the health of highly paid individuals, while the friction cost approach assigns greater value to restoring the health of those with highly skilled jobs that require extensive education, training, or professional qualifications. And it might be that we don't want the allocation of resources within our public healthcare systems to be biased towards individuals on the basis of their income or the basis of their skills. It might contravene some basic values that we have. So we're going to start off with a question here. I'd like you to imagine in principle that there are two patients with identical health conditions and an identical capacity to derive health benefits from treatment. My question is, should these patients be treated differently by a Canadian public healthcare system purely on the basis that one is a highly paid professional and the other is unemployed? Now, before we answer that question, the elephant in the room here is that we do not conduct economic evaluation on this sort of granular level. Nobody's doing economic evaluations for each individual coming into the emergency room, for example. But right now we're just exploring some principles, and in a few minutes we will take those principles and apply them to the level of the subgroup or the entire population, which is how economic evaluations are actually done in practice. So as a matter of principle, should a Canadian public healthcare system treat these individuals differently? A highly paid professional or an individual that is unemployed? And one possible answer to this, which we'll call answer A, is yes, the patient should be treated differently. Treating the professional and returning them to work would increase economic growth and tax revenues, yet fewer economic benefits would arise from treating the unemployed patient. Given scarce public health care resources, it is rational to prioritise care for the highly paid professional and to deprioritise care for the unemployed patient. So that's one possible answer. Another possible answer, which we'll call answer B, is no, the patient should be treated identically. Two key objectives of Canadian health policy are to provide, quote, access to quality healthcare without financial or other barriers, and to make progress in, quote, treating sickness and alleviating the consequences of disease and disability among all income groups. It follows that an individual's productivity, their income, or anything related to it, should not be considered when allocating public healthcare resources. And if you're wondering where those quotes came from, those objectives, they come from the preamble to the Canada Health Act. Under a societal perspective, a greater value would be assigned to treating the highly paid professional in this example if treatment allows each patient to return to work sooner. It follows that an effective but expensive treatment might be found to be cost effective for the highly paid professional, but not for the unemployed patient. This difference would arise solely due to differences in these individuals' incomes and employments, and hence productivity, and not due to any differences in their capacity to derive health benefits from treatment. However, under a publicly funded healthcare payer perspective, the value of treating each patient would be identical, and this is because the health effects arising from treatment are identical for each patient, and this is the only outcome considered under this perspective. Any differences between the individuals in terms of productivity would not be considered, and so would not impact on the results of the economic evaluation. Let's move on to a follow-up question now. Can we avoid this potential discrimination by using a single average estimate of productivity for all members of the target population, or for every member of society? Now, applying an average estimate of productivity to all members of a population subgroup would indeed avoid individual level discrimination on the basis of productivity within that subgroup. However, average productivity would still be expected to differ across population subgroups due to differences in the composition of these subgroups by age, sex, gender, race, and or other characteristics, all of which have differences at the population level in terms of aggregate production, productivity, such that discrimination would still arise at the subgroup level. So, for example, consider a condition that primarily occurs in a retired population, such as lung cancer. Since average economic productivity is lower in retirement, any productivity gains from treating these patients will be limited relative to those from treating other populations, other working age Canadians. A societal perspective that averages productivity across all patients in a technology's target population would still discriminate against patients in subgroups like these with lower average productivity than other subgroups. So aggregating across the entire target population for treatment is not an adequate solution, right? If we're concerned with this discrimination. So what if we were to aggregate across every member of society? If we assume the same productivity for every member of society? And there's a real problem with this, which is that this approach does not reflect real-world productivity in any meaningful sense. It is simply incorrect to assume that every member of society has the same productivity. A patient who is on their deathbed, they're at the end of life, does not have the same economic productivity as a healthy, fit, working age individual. That is simply not the case. And if we think that we should treat an individual at the end of life who is not productive anymore in the labour market, if we think we should treat them the same way as an individual who is highly productive, well then we should not be considering productivity within any analysis, including the economic evaluation that informs the decision. So I think a better approach would be to recognize that productivity by its very nature differs from one individual to another. And if society takes actual productivity into account when allocating healthcare resources, it must recognize that this will inevitably disadvantage some individuals, those with lower productivity. And if this is considered unacceptable, the only solution is for society to not take productivity into account when allocating limited healthcare resources. I don't think it's an acceptable approach to pretend that every individual in society has the same productivity when that is not the case. You are not measuring productivity by making that assumption. Let's return to that paper on options appraisal that was presented at the NICE board meeting in December 2022. And what do they have to say about this? So we go to paragraph 32. An implication of this is that older and non-working populations will be disadvantaged because no productivity benefits will be associated the interventions affecting them. Over time, NHS and other public resources may shift towards interventions that affect young or working age populations for whom this extra value is added and a positive recommendation decision is more likely. This could come into conflict with NHS principles of equality of access to healthcare based on need. It could also be interpreted as age discrimination, which is a protected characteristic under the Equality Act of 2010. These concerns motivated Swedish HTA agency TLV to switch from a partial societal perspective that included productivity costs to a health sector perspective in 2015. And in Canada, we don't have the Equality Act of 2010, but we do have the protections of the Charter of Rights and Freedoms, Section 15, which prohibits discrimination on a number of protected grounds. There would be, I think, serious issues with changing CADTH's perspective in a way that would prioritize healthy working age individuals who have the highest incomes, which, by the way, there's plenty of data to show that men have higher incomes than women. There are higher incomes for certain races than others. There's all sorts of discrimination that could creep in here if we choose to bring people's labour market productivity or even an estimate of people's non-market productivity. Even if we attempt to assign a value to that, there's all sorts of discrimination that is going to come in here. And the concerns that are raised in this document by NICE would apply equally to any change to a societal perspective by CADTH. Let's now move on to two other things considered under a societal perspective. Recall that a societal perspective considers reduction in criminal behaviour and better educational achievements. These are taken from the CADTH guidelines. So let's take that question we asked a few minutes ago and rephrase it. In principle, should two individuals with identical health conditions and an identical capacity to derive health benefits from treatment be treated differently by a Canadian public health system on the basis that one is a university student with high earning potential, while the other is a high school dropout with a much lower earning potential? And we could rephrase the question again. Should they be treated differently on the basis that one is a career criminal who plans to commit further crimes following treatment, while the other is a law-abiding member of the public? And one way of answering these, answer A, would be yes, the patient should be treated differently. We should prioritise treatment for patients who have the greatest educational potential and deprioritise treatment for any patients who engage in criminal behaviour, since doing so maximises economic benefits for society. And another answer, answer B, would be no, the patient should be treated identically. Canada's public healthcare system should treat patients solely on the basis of their clinical need. If two patients have the same capacity to derive health benefits from a given treatment, they should be treated identically, regardless of their educational potential, criminal record, or any other non-health characteristics. And so this brings me to another recommendation, which is, I believe that before making any revision to its perspective, CADTH should provide clarity as to its position on these fundamental normative issues. If it is the case that CADTH wishes to avoid discrimination on the basis of any non-health related characteristics such as productivity or educational achievement, then it should not adopt a societal perspective. Let's now move on to the appropriateness of CADTH's $50,000 per QALY informal cost effectiveness threshold. And before we continue, if you were to ask anyone at CADTH what their threshold is, they would likely respond that they don't have a threshold. There is no formal threshold. And indeed, in CADTH's guidelines, there is no mention of a threshold. However, if you look at any reimbursement recommendation from CADTH, and this one here is a recommendation from just a month ago, published in December 2023. This is for Trikafta. And if you look inside that document, you will find statements such as the following. At these ICEs, Trikafta is not cost effective at a $50,000 per QALY gained willingness to pay threshold. That's CADTH's term, threshold. A price reduction is required for Trikafta to be considered cost-effective at a $50,000 per QALY gain threshold. And they use these thresholds to calculate the price reduction that a payer or the PCPA should try and negotiate from the manufacturer. So you can see in the second quote here, a price reduction in excess of 94% for Trikafta is required for Trikafta to be considered cost-effective at a willingness to pay threshold of $50,000. So with a different willingness to pay threshold, you would have a different price reduction. So regardless of whether or not CADTH considers that it has a formal threshold or not, this $50,000 per QALY does appear in CADTH's guidelines, and it is used for an extremely important purpose, which is to determine what that price reduction is for a technology to appear cost effective. So what is that threshold? Let's just return to this slide for a moment. So under a publicly funded health system perspective, we have the expected health improvements, the expected health losses. And one question would be, what are those expected health losses? The expected health improvements are pretty easy to understand. CADTH's economic evaluations report these, the incremental QALYs provided by a technology. But what are those expected health losses? Those are not reported by CADTH in its economic evaluations. So what are they? The expected health losses are estimated by considering how else the payer could otherwise invest the dollars required to adopt the new technology. So suppose these dollars could be invested in reducing waiting lists for other treatments. And for the sake of argument, suppose that doing this would provide one QALY for every $30,000 invested. So if we were to invest in reducing waiting lists across Canada, every $30,000 we invest in that would provide one QALY of benefit to patients. Now, if that were the case, and if the new technology were to be adopted instead, then the expected health loss, how much health we have foregone by paying for this new technology instead of reducing waiting lists, that expected health loss is going to be one QALY for every $30,000 allocated to the new technology. So, for example, if this new technology has an incremental cost, which is reported by CADTH, if that incremental cost is $300,000, you would divide that by the $30,000 in this case, and the expected health loss would be 10 QALYs. Every technology has a different incremental cost, which is reported by CADTH. And then all we need in addition to that is an estimate of how else you could spend those dollars. What is that return in spending those dollars elsewhere within the healthcare system? Is it one QALY for every 30,000 or one QALY for every 50,000? What is that number? Once you have an estimate of that number, you can calculate the expected health loss from the incremental cost. And work has been done all around the world trying to estimate what this marginal cost of a unit of health, a QALY, for example, what is that marginal cost? How much do we need to invest in our public healthcare systems in order to generate a QALY? And these estimates have been done for many, many countries around the world. Unfortunately, not Canada yet. There's been no peer-reviewed studies done in Canada so far. That said, there was some research done by the University of York, who published the UK estimate that was in that review on the previous slide. They did work in 2018 on behalf of the PMPRB, which is a federal agency in Ottawa that regulates patented medicine prices in Canada. And that work estimated that marginal investments in Canada's public healthcare systems would provide approximately one QALY for every $30,000 invested. So that's where I got that number from that was on the previous slide. If you're interested in reading this study, you can download it from this forwarding URL on this slide. A recent systematic review by an international team of authors identified peer-reviewed estimates of the marginal investment required to produce one QALY within the public health systems of a number of developed countries. We just saw that study, the CADTH study. And between these studies, there were 4 that are of particular interest to Canada. So the studies that were done in England, Australia, Spain, and Sweden, all of these are developed countries. They all have public healthcare systems. They are all on the PMPRB 11 list, which is a list used for reference pricing by the PMPRB. So these countries are sufficiently similar to Canada that we can use the prices of medicines in those countries for the purpose of reference pricing. And so it stands to reason that the marginal investment required to generate a QALY within those public healthcare systems is going to be in the same ballpark as it would be in Canada. Now, there's not been an estimate for Canada yet, as I mentioned a few moments ago. However, in an unpublished white paper that I prepared for CADTH in 2022, I converted these estimates from these 4 countries into Canadian dollars, accounting for both inflation and purchasing power parity. And the median of those estimates was very, very close to $30,000 Canadian for every QALY. The mean was slightly higher than that, but still well below $40,000 and certainly below $50,000, which is the informal threshold that CADTH currently uses. So those international estimates convert to about $30,000, very similar to that work by the University of York. And this estimate is critically important for informing any cost-effectiveness threshold used by a payer in Canada. Population health is improved by funding new technologies for which the incremental cost-effectiveness ratio, or ICER, is below this estimate. And conversely, population health is diminished by funding technologies for which the ICER is above this estimate. So if $30,000 per QALY is an accurate estimate of the expected return from investing in marginal healthcare services within Canada's public healthcare systems, this raises questions about the $50,000 per QALY informal threshold currently used by CADTH. For example, suppose there's a new health technology with an ICER of exactly $50,000 per QALY. That would be considered cost-effective by CADTH. However, every incremental $150,000 invested in this new technology would be expected to provide 3 QALYs. 150,000 divided by 50,000, compared to 5 QALYs, 150,000 divided by 30,000, if the same dollars were invested in other marginal healthcare services, resulted in an expected health loss of 2 QALYs. We would get an additional 2 QALYs if we did not pay for this new health technology and we put the same dollars, that $150,000, into other uses, such as reducing waiting lists across Canada. There would be a net loss of 2 QALYs by putting that $150,000 into this new technology instead. This is assuming that that $30,000 per QALY is an accurate estimate of the expected return from investing in marginal healthcare. And this leads me to another recommendation. CADTH should base its informal threshold on the expected return from investing in marginal healthcare services within Canada's public healthcare systems. Current evidence, which is limited, suggests that technologies priced up to $50,000 per QALY may not improve population health. That current evidence suggests that the number is closer to 30,000 rather than 50,000. However, that evidence is very limited, so CADTH should support further research to generate more robust estimates of this expected return. Let's now move on to the impact of adopting a societal perspective. So a few minutes ago, we talked about how under a publicly funded health system perspective, we're comparing the expected health improvements to the expected health losses. Under a societal perspective, instead, we are considering the expected societal benefits. So our consideration of the expected benefits arising from new technologies would need to be broader, encompassing not only expected health improvements, but also the many non-health impacts that we've considered earlier in this presentation. So we don't just have health gains, we have expected societal improvements. Okay, so yes, we've got those health benefits, but we might also have productivity improvements and many, many other societal improvements. Furthermore, CADTH's consideration of the expected losses would need to be broader, encompassing not only health losses, but also the societal implications of those health losses, including productivity and consumption losses for patients and their caregivers, and impacts on private insurers. So it goes both ways. It cuts both ways. If we're going to move to a societal perspective, it's not only the benefits of new technologies that are now broader, it's also those opportunity costs. So if we were to invest the incremental costs of a new technology instead on shortening waiting lists, it's not only the health improvements that we would get from shortening waiting lists, it's also the fact that those individuals who are now on shorter waiting lists can return to work sooner. They're more productive. They are less likely to need to pay for treatment through private insurance. Okay, so it would have impacts on private insurers. There's all sorts of societal benefits that will arise from having shorter waiting lists or having more family doctors. Right? Whatever those the most desirable alternative use of those dollars is, whatever that is, will provide not only health benefits, but societal benefits as well. And so by not spending our money on those things, by spending our money on the new technology, there are expected societal losses. And under a societal perspective, a treatment is considered cost effective if funding it is expected to have a positive incremental net benefit, taking into account population health, any non-health impacts, and the value assigned to each. So this is another challenge that we have under a societal perspective, which is when you move beyond only health being the consideration, and you have other things like productivity or educational outcomes, you need to trade all of these things off. So you need to assign a value to health relative to educational achievement or relative to productivity gains. Okay, we maybe need to value everything in dollars. Okay, so you need to put a dollar value on those health benefits. This is something that we don't need to do from the health payer perspective, from the public health payer perspective, because the only outcome is health. So we don't actually need to put a dollar value on health. We just need to consider whether a technology provides more health benefits than losses. But from a societal perspective, we need to trade all of these different things off. It also raises the potential that the most cost-effective option might not be the one that improves health the most. There might be one option that has smaller health benefits, but greater other societal benefits. And so our healthcare system might choose a treatment strategy that does not maximize health. It maximizes the social value, but not health. And so we're moving away from improving, maximizing population health outcomes, right, towards maximizing societal outcomes. Now, the flip side of this is if a treatment has negative incremental net benefit, taking into account population health, any non-health impacts, the value assigned to each, if this is negative, well, then that's considered not cost effective. And it is possible for a treatment that is cost effective from one perspective to not be cost effective from another. A treatment that improves population health outcomes might have some negative societal implications, and it is not considered cost effective from this perspective, and vice versa. There might be a treatment that does not improve population health, but there are sufficiently great societal benefits, greater than the opportunity costs from a societal perspective, that make it appear cost effective from this perspective. This brings us on to question 3, which is, would CADTH need to adjust its $50,000 per QALY informal threshold if it adopts a societal perspective? And the short answer is yes. CADTH would need to adjust its threshold. Adopting a societal perspective impacts how we value the opportunity cost associated with reimbursing health technologies within Canada's public healthcare systems. This in turn has important implications for CADTH's informal cost effectiveness threshold. So, from a publicly funded healthcare payer perspective, the only relevant outcome are health effects. And so it follows that the only consideration for the opportunity cost is the health benefit forgone by other patients due to fewer resources being available for their healthcare. But the moment we move to a societal perspective, consideration of that opportunity cost is now much broader. Every category of costs or outcomes taken into consideration when evaluating the benefits of a health technology must also be taken into account when considering the opportunity cost. And for a recent paper that explores this further, I can recommend this paper that was published last year in Applied Health Economics and Health Policy, the broader opportunity costs in the broader cost effectiveness analysis framework. You broaden the perspective to a societal perspective, you need to broaden your consideration of opportunity costs, and the hurdle that technologies need to clear to be considered cost effective is now higher than it was before. Sure, there are additional benefits being considered, but the hurdle is greater as well, and it's vital that CADTH takes that into account if it moves to a societal perspective. If we return to that NICE document, you can see they said something very similar. There are also significant evidence gaps on the wider societal benefits of currently provided services that were likely to be displaced by new interventions. Given that NICE formally acknowledges the health effects of displaced services when making its recommendations, the same approach should be taken were wider societal effects to be routinely included in its assessments. This would require NICE to investigate if and how its cost effectiveness threshold should be changed. So a follow-up question is, in what direction would CADTH need to adjust its threshold, and by how much? And one informative way of getting it would be to consider by how much do we expect societal incremental cost effectiveness ratios to be lower than incremental cost effectiveness ratios from a public health payer perspective. And a very recent paper, 2020, a large systematic review by Kim et al. Reviewed almost 7,000 cost per quality studies published internationally from 1974 to 2018. And this is a quote taken from this paper. Based on 16 cost per quality studies, recent studies, so 2017 to 2018 only, based on those 16 studies, reporting 68 ICERs from both the healthcare sector and societal perspectives. So just to stop one moment here, they've taken those 7,000 studies and they've focused on 16 which provide both a healthcare payer and a societal perspective and are recent, so from 2017 to 2018, just that subset of papers. The median ICER from a societal perspective, approximately $22,710 US, was more favorable than from a healthcare sector perspective, so $30,402. And so the takeaway from this is that the median ICER is 25% lower from a societal perspective. Okay, that's a really substantial difference. So we might expect that if CADTH were to move to a societal perspective, the typical technology that CADTH would be reviewing would have an ICER approximately 25% lower. Obviously not in every case, there will be exceptions, but the median will be substantially lower. And if you're interested in that paper, here's the details of that paper published in Pharmacoeconomics in 2020. And a key unknown here is whether the observed reduction in the ICER for the technologies in the Kim paper is greater than, less than, or similar to the reduction in the ICER for the marginal investment opportunities that comprise the opportunity cost of reimbursing new technologies within Canada. So for example, shortening waiting lists across Canada. If these are similar, then CADTH's threshold should be reduced by around 25% under a societal perspective. If we expect that the societal implications of that marginal investment opportunity is even greater than the average observed in the Kim paper, well then we need a more substantial reduction than 25%. And if we expect that those societal implications are less than what we've observed in the Kim paper, it would be a smaller reduction. But in the absence of any information on this, I would say a reasonable assumption is that they are similar. And so we are looking at a reduction in CADTH threshold in the ballpark of 25%, a really substantial reduction under a societal perspective. Furthermore, a change in CADTH's perspective would not result in a change to provincial healthcare budgets. Logically, the total net budget impact of all cost-effective technologies and services funded within each of these budgets cannot increase following a change in the perspective. There are no additional dollars in the system. If CADTH were to adopt a societal perspective, and as a result, they start finding more and more technologies to be cost-effective, because the ICERs are lower, they are recommending smaller reductions in the price. If that were the case, well, it's going to hit up against the wall of reality, which is that there's no additional dollars in these public healthcare systems to do that. Logically, the total net budget impact of all of the services and technologies that are considered cost effective has not changed. It cannot change. The composition will change. We would expect under a societal perspective that those technologies that are considered cost effective will change. There'll be some that are no longer considered cost effective. But the total net budget impact cannot increase by definition. And so it follows that unless technologies reviewed by CADTH systematically differ from other investment opportunities in terms of their societal benefits, implementation of a societal perspective should not result in any systematic change in the number of technologies found to be cost effective by CADTH, nor any systematic change in the average price reduction required for technologies to appear cost effective. And again, there will be changes for certain technologies. There will be some technologies which under a societal perspective appear more cost effective, but there will also be technologies that appear less cost effective. If CADTH were to implement a societal perspective and to do it consistently, there will be cases where a technology provides benefits maybe at the end of life for patients who are not particularly productive compared to those patients who are on waiting lists. Working age individuals on waiting lists. And if you were to provide that technology, the societal benefits foregone would be greater than the societal benefits gained. And as a result, that technology is less cost effective under a societal perspective. Okay, and it's absolutely crucial that CADTH would take that into account if it were to move to a societal perspective. So my recommendation here is, if CADTH were to adopt a societal perspective, it should reduce its informal $50,000 per QALY threshold so that it is consistent with the broader consideration of opportunity costs under a societal perspective. Based on the findings of the Kim et al. Paper from 2022, an approximately 25% reduction may be required, reducing CADTH threshold to $37,500 per QALY. But of course, if CADTH were to adopt a societal perspective, I would recommend that they commission some research on this. Okay, don't just take my word for it. Do some research on this, but be very clear that we are potentially looking at a substantial reduction in the threshold under a societal perspective. There's another follow-up question here, which is, what if CADTH were to adopt a societal perspective without making any revisions to its informal cost-effectiveness threshold? And because those ICERs that were found by Kim to be around 25% lower under a societal perspective, any adoption of a societal perspective by CADTH without a corresponding reduction in its threshold would open the door to higher prices for new health technologies. And because public health budgets across Canada would remain constrained, this would be expected to reduce overall population health outcomes. Where you have the same budget as before, if you have higher prices because the ICERs that CADTH are now calculating are lower than they were before and the threshold has not changed, as a result, prices will go up. Given the constrained budget, we would expect population health outcomes to decline. And let's have a look at what the NICE paper had to say about this, because they made a very similar point to what I'm making now. The inclusion of these benefits under a wider societal perspective would be expected to only add value to interventions that are already more effective. This in turn could motivate manufacturers of health technologies to increase what they consider to be the economically justifiable price for the NHS. Under a health sector perspective, these wider benefits accrue to society incidentally, but they would not justify a higher price. Reducing their relatively high pharmaceutical expenditures among OECD countries was the motivation for Portuguese HTA agency Infarmed to switch to a health sector perspective in 2019, having previously included productivity costs under a wider societal perspective. The inclusion of productivity savings from more effective treatments resulted in lower incremental cost-effectiveness ratios, which were then used by manufacturers to justify higher prices during negotiations. And it is entirely predictable that if CADTH were to move to a societal perspective, this is what we would find. Lower ICERs that are then being used by manufacturers to justify higher prices. And it's extremely important that CADTH lowers its threshold and makes clear that the opportunity cost has now changed as well. And in some cases, that will justify a higher price. In some cases, it will require a lower price than it would under CADTH's current perspective. So any adoption of a societal perspective by CADTH without a corresponding reduction in its threshold would also raise the possibility that a new technology could be considered cost-effective by CADTH when its reimbursement by a Canadian public payer would be expected to not only worsen population health outcomes, but also worsen broader societal outcomes. And this is quite an important finding. And to illustrate this, we're going to use a very simple example. So just suppose that a payer can invest $1 million into a new technology, or invest the same amount into reducing waiting lists. And for the sake of argument, suppose that reducing waiting lists would provide 20 QALYs in return for that $1 million investment. So we're getting a return of $50,000 per QALY. As I mentioned earlier, the empirical research that's been done to date would suggest maybe more QALYs than that. It would be about $30,000 per QALY. But for the sake of argument, let's use 20. Let's keep the numbers simple. Suppose that a new technology provides 25 QALYs for that $1 million. So that's an ISA that is $40,000 per QALY. And that would be considered cost effective. We're getting 25 QALYs instead of 20. Notice how the ISA is lower than that 50,000. Alternatively, suppose this new technology provided 15 QALYs for that $1 million. So that's a higher ISA now, 67,000, and that would not be considered cost effective. So you can see how the comparison of a technology's ISA to this threshold, this $50,000, the cost per QALY for reducing waiting lists or whatever the alternative use of those dollars is. By comparing the ISA of the technology to that threshold, we can determine whether a technology provides more QALYs or fewer QALYs, more QALYs or fewer QALYs than the opportunity cost. Now, an alternative to calculating these ISAs would be to say, well, by reducing waiting lists, we get 20 QALYs. Let's value them at $50,000 each. A QALY is worth $50,000. And so the total value is $1 million. And for the new technology, those 15 QALYs are valued at $50,000 each. That's worth 750,000 QALYs. So this is a net benefit approach rather than using ISAs. But at this point, it's entirely equivalent. We would still find that the new technology is not cost effective, just like when we compare the ISA of the new technology to that threshold. But now suppose that you're CADTH and you are adopting a societal perspective, but you are not going to change your threshold. So that left-hand side of the screen, which is the opportunity cost, we're not going to consider that. We're just going to apply a societal perspective for the new technology on the right-hand side of the screen. So we're going to remove the total value there. We're going to add in the societal benefits. Let's assume that it's $500,000 of broader societal benefits beyond health. And so the total value is the 750,000 value of the health gains plus $500,000, so 1.25 million. And at this point, this is looking good, right? The new technology appears cost effective. And this is what would happen if you then rolled up that total value into an ISA and compared it to the $50,000 threshold. You would have an ISA, once you've incorporated those societal benefits, that is lower than $50,000 per QALY, and it would appear cost effective. But there's clearly a problem here, which is that we've not considered the societal benefits of reducing waiting lists. So if we go back to the drawing board and we say, well, what are those? Imagine for the sake of argument that they're slightly higher, they're $600,000. So the total value of reducing waiting lists is actually 1.6 million. In that case, the technology is not cost effective. But you can see how an approach of adopting a societal perspective, but only partially, only considering the societal benefits for the new technology and not considering the opportunity cost side of the equation, that would have resulted in the wrong decision. It would have resulted in CADTH saying this technology is cost effective because the total value of the health gains and the societal benefits is greater than the health losses. Well, yes, it is, but once you bring into account not just the health losses, but the societal losses as well, then this technology is not cost effective. And you can see that in this particular example, this new technology does not only diminish population health because it provides 15 QALYs and displaces 20, but it also has worse societal outcomes. There's $500,000 of societal benefits versus $600,000 for reducing waiting lists. Okay, so this is a technology that is really not cost effective from either perspective, and yet it would be if a societal perspective was implemented without adjusting the threshold. So my recommendation is that CADTH should not adopt a societal perspective unless it is prepared to make a corresponding adjustment to its cost effectiveness threshold. Doing so would be expected to diminish population health outcomes and possibly societal outcomes. Although it would favour the manufacturers of new technologies and patients who benefit from new technologies, it would cause harm to other patients treated within Canada's public healthcare systems. And I think it's very important that CADTH gives a voice not only to the patients that stand to benefit from new technologies, but to every patient that is impacted by its recommendations. If CADTH is recommending that a technology be reimbursed, and if reimbursing that technology has implications that go beyond the patients who benefit from that technology, I think that CADTH has an obligation to take the negative health impacts on those other patients into account and give them exactly the same weight as the health gains for the patients who would stand to benefit if the technology were funded. Every patient deserves an equal voice at the decision-making table. And that for that reason, a societal perspective should not be adopted unless a corresponding adjustment is made to the cost-effectiveness threshold so that all patients, whether they benefit from the technology or they lose out, are given the same consideration by CADTH at the decision-making table. So what are my final recommendations? I've made a number of recommendations as we go along, but what are my final thoughts here? Let's look at what NICE recommended in the document from 2022. We recommend that the board approve option 2 and retain the existing approach, so that healthcare payer perspective, not a societal perspective, while strengthening processes within NICE so that existing flexibilities are utilised optimally and consistently. The health sector perspective outlined in the reference case is appropriate for many interventions and technologies considered by NICE and sets a clear objective of securing the best possible health outcomes for NHS resources. We find that existing flexibilities to incorporate wider effects in NICE methods are appropriate. However, although we did not identify instances where the current arrangements did not allow for relevant wider effects to be considered in an assessment, the process improvements recommended in option 2 will reduce the possibility that this could occur. So broadly what they're saying is keep the current reference case perspective, which is the same as CADTH's, but make it very clear what the processes are for considering broader perspectives in those cases where it's considered appropriate. Make sure that that's consistent across all of NICE's evaluations. They go on, despite legitimate theoretical arguments in favour of formally adopting a wider societal perspective, there are also substantial ethical, practical and methodological challenges that must be addressed for it to be implemented successfully and in line with NICE principles. Significant amounts of NICE resources over multiple years would be required to facilitate engagement with public institutions and other stakeholders and address the methods and evidence needs. We note that the commitment to these resources may not improve the quality of NICE recommendations and would likely limit NICE's ability to address other current priorities and strategic aims, and therefore do not recommend this option. And let's be clear, this applies equally, if not more so, to CADTH as it does to NICE. So if CADTH were to try and adopt a societal perspective, it would substantially increase the resources required by their economics team to do a good job with these economic evaluations. Each economic evaluation would be much more complicated, and there would be all sorts of challenges. For example, what do you do when a manufacturer cherry picks which aspects of the societal perspective to include? CADTH's economic team would then have to try and fill in the gaps and do so in a consistent way across all of the economic evaluations that CADTH considers. So this would require substantially more resources, and it would not improve the health of the population. And unless an adjustment is made to the cost effectiveness threshold, it would not necessarily improve broader societal outcomes either. In fact, it could harm them. Okay, and adjusting that cost effectiveness threshold is extremely challenging. If we then look at the minutes from the NICE public board meeting where this document was presented, we can see what NICE board's decision was. And they said, having considered the analysis set out in the paper, the board supported the recommendation to retain the current approach to economic analysis and strengthen NICE processes to ensure consistent application of the current flexibilities so that assessments include wider costs and effects when particularly relevant. The board highlighted the importance of providing the committees with clear written guidance on when the flexibilities could be used, along with training. The board also asked that the impact of using these flexibilities is kept under review and asked to receive a progress update, including information on when a wider perspective has impacted recommendations at a suitable future date. So what's my recommendation to CADTH? CADTH should retain its current recommendation of a publicly funded healthcare payer perspective as the reference case perspective, with the flexibility to consider broader perspectives within a non-reference case analysis. That is the current position, and I would recommend that CADTH maintain that current position. CADTH should follow NICE's lead and take steps to ensure that this flexibility is applied consistently across all economic evaluations it considers. Before considering any potential change to its perspective, CADTH should commission research into the expected impact on patients, including the potential for discrimination, and also the expected impact that such a change would have on CADTH's informal cost effectiveness threshold. The consequences of an incomplete or inconsistent implementation of a societal perspective are serious, including a reduction in population health outcomes and possibly, as we've seen, a reduction in economic outcomes, societal outcomes as well. So a partial and incomplete application of a societal perspective could very easily cause more harm than good, and I would strongly recommend CADTH not to do that. You can download these slides from cadth-perspective.mikepoulin.org or by scanning this QR code. Thanks very much for listening.